Insights from the world's best medical minds. You are watching TheRightDoctors.com.
Welcome all my friends for this online session on vascular surgery, and I shall talk to you over the next 15-20 minutes and take your questions at the end. I am Dr. Unnikrishnan. I have had 35 years of my professional life in Sri Chitra Institute, Trivandrum. Currently, after retirement, I am at SUT Hospital, that too in Trivandrum. And I would like to talk to you on common vascular diseases and their treatment. Of course, that will include complex procedures as well. Vascular sciences has three components: open conservative surgery, and the endovascular surgery, which is now evolving into a great forefront, and vascular medicine. These are the three components of vascular sciences and the management that we do for vascular surgery. Now, again, vessels are arterial, venous, AV malformation, that is a combination of arterial and venous, and lymphatic. But predominantly, it's arterial disease and aortic diseases, whereas venous disease is next in line, and AV malformation and lymphatics form a small percentage of problems in front of the vascular surgeons. Now, the arteries supplying various organs, they have this steno-occlusive phenomenon because of the atherosclerotic plaque, and very much less of aneurysms in the arteries. In contrast to aorta, the major artery lifeline for all the systems to function, it is the aneurysm, but usually towards the terminal aorta, occlusive disease is more common with aneurysm. Now, if you see the picture on the left side, I'm sorry, it's a little turned, you find the plaque, which is typical I have taken from carotid plaque. The vulnerable plaque means it has got abundant cholesterol and atheromatous material, a lot of inflammatory lymphocytes, and a very thin fibrous cap, very thin. And that makes it vulnerable component, which is prone for rupture, ulceration, clot formation, and embolism. In contrast, you find in the middle, the fibrous plaque, which is not so vulnerable, and it is rather stable, grows slowly. And the vulnerable plaque is the epicenter of all diseases, especially in the cardiac and the cerebral circulation that we see. And you see the one on the rightmost side, you see the aorta. The aorta is about 1.5 to 2.5 centimeter at various levels, but the atheromatous changes in the media weakens the aortic wall, forming aneurysms, which I'm sure that you will be knowing it. Now, the risk factors, unlike most people think, there are two major risk factors, that is male gender and an age above 65. So these are the true risk factors. But of course, the smoking, diabetes, hypertension, obesity, hypercholesteremia, and physical inactivity is very important, although I mentioned that the last one, very important, additives, or I think these are the factors worsening the disease pattern and producing an acute or chronic situation for patients. And the physical examination for the peripheral arterial system, which is very important in the upper and lower limbs, pulse examination, followed by Doppler evaluation and angle brachial index, gives you an idea. Then, of course, you would have heard of duplex examination, tells you the ultrasonic feature, along with the Doppler, which tells you the texture, the flow pattern, the systolic velocity, and the post-plaque blood flow available. Also, the calcification, if it's any, and the stenosis, which is what is the percentage. All this will have a bearing on patients, coupled with their symptoms, for the selection of the management. And you have, of course, a confirmative modality is CT scan. Most of us, I would say, at least in India, we almost always go for a contrast CT scan because it is the confirming investigation, tell you what is in the Doppler And then, of course, coupled with the symptoms and signs we get, we go decide on the treatment, because a lone duplex scan, standalone, it does not decide any treatment mostly, except mostly in the venous side, we may not go for that. Also, we go for CT scan unless we have a confirmation of the problem. I think the treatment can be quite tricky and may not be effective. Now, MR is not that much used. Now, there is, of course, a good planning for any treatment with the, the vascular surgeon as the leader, and of course, the supportive, maybe interventional radiologist, maybe cardiologist, maybe physicians, diabetologists, or whatsoever. Now, why I'm mentioning this is this management is common, and the best medical management is mandatory for any vascular treatment you do it, whether it's going to be stenting, angioplasty, endovascular surgery, or open surgery. So lifestyle modification has to be followed, absence of smoking and control of diabetes, and of course the graded walking. It will help the patients to be a little more fit, plus the food is digested and they don't go into obesity much, and their activity is maintained. And many of them will have cardiac problems. So that also taken care, including a step down in the treatment for diabetes and hypertension as well. And of course, medication will be required for many patients. Then, of course, the next option is the angioplasty or endovascular intervention, is the minimally invasive keyhole surgery, akin to many surgical procedures in other specialties. And this, of course, it's a keyhole surgery, and you don't need a big incision. Patient can go home in a day or two. Then, of course, stenting whenever required, whenever indicated, especially in longer lesions. Then the endovascular aneurysm repair is now in the forefront of treatment of aneurysms, in contrast to the open surgery, which was the only modality earlier. Last 10-15 years in India, most of us do aneurysm repair in the endovascular way with great results and less morbidity for the patient. And of course, I'll be alluding to more about when I come to talk about the aneurysm repair. Then, of course, open surgery is the last option. Still, in many situations, it is durable and less of surveillance problem. Again, I'll come back to you on the differences, indications, and benefits and costs about the surgical pattern that we optionally take up. Now, I will be mostly basing my talk on my experiences at Sri Chitra Institute. I mentioned more than 450 procedures, open procedures I would have done. In our center, interventional radiology used to do it, and along with a discussion, the patients are admitted with us, and the decision is made, but the occlusive, steno-occlusive lesions are tackled. Now here, where in my new hospital, cardiologists do, because I'm more comfortable open, and it's all a teamwork in any vascular disease management. Carotid endarterectomy, I've been fortunate to do 295 procedures, and open abdominal aortic aneurysm 365. Thoracoabdominal aneurysm, we have one of the largest numbers in 128 procedures. And endovascular aneurysm for abdomen is 20, because we have a high propensity to do open surgery for reasons that I'll be alluding again. Whereas in the thoracic domain, we do more of endovascular surgery for the reasons which I'll be talking to you about. Now, angle brachial index of 0.7 or less, and then a combination of intima medial thickness is a marker for atherosclerosis that can hide, and the patient can come with a hidden agenda of coronary disease, or when you have a carotid disease and a peripheral artery disease, the coronary disease has to be evaluated, because it's the generalized disease with a segmental predilection that produces at the arterial origins and bifurcations. That is the most hemodynamic stressed area. So you have the problem, multiple sites, and of varying kind of intensity. I think I don't want to go into this slide, and that shows the carotid plaque. Now, normal ABI is very important, 0.9 to 1.1. 0.8, I think it's just about acceptable. Less than that is abnormal. You got to look in the patient's symptoms, the activity level, and of course the cardiac also that may be hidden. And intraproprietary disease, 50% to the attune, you have coronary artery disease. And PAD with the carotid artery, as I mentioned, there's a high probability of coronary disease. Why I repeatedly mention is 75% of mortality in any vascular interventional surgery is because of cardiac. And we don't want, patient doesn't want to lose life when we are trying to improve the leg or anything. So that part has to be looked at carefully so that we have to make an assessment, non-invasive or invasive, as the patient-centric approach by the vascular surgeon. Now, I think this I have already repeatedly told. And of course, the lifestyle modifications in any form of treatment for any domain vascular procedures. Quit smoking is mandatory. It causes recurrence, suboptimal results when the patient's going to continue smoking. And of course, diabetic and hypertension causing the stress. It accentuates the worsening of any lesion. Of course, diet discipline, as we all understand, some amount of physical activity will help in keeping the patients a little fit, less of cholesterol level for the body, and further recurrent disease after a primary procedure. And for primary procedure, the primary procedure, it's a secondary prevention, but for other carotid or coronary time, it is the primary procedure itself. The lesions can get less and less and may not require, provided they go through this lifestyle modifications and medications, of course, antiplatelet, statins, silestazole, all that I think you are aware. In the interventional or a keyhole surgery, minimally invasive, you have balloon angioplasty, stenting, and nowadays there is more and more prevalence of hybrid procedure and along with the bypass procedure, so that you can improve the antegrade flow, so that the bypass procedure works, especially in iliac and femoral disease, which is very commonly done. There are situations where we should be careful in selecting. This patient has an angiogram, the whole superficial femoral artery is blocked, but great amount of collaterals, had a ADI of 0.7. He was walking about half kilometer. I left him alone. Now with all these modifications, he's able to walk 1 kilometer. At this rate, he may not need a bypass graft. When he needs, he may go for a bypass graft. So it is all multiple factors that you take in decision for intervention or even surgery. In contrast, another lady was brought to me in the evening. She has had a second procedure for fixing her fracture, and then they found there was no pulse. And then you can see the middle portion, I think the callus or the bone chips had punctured or, it's obstructed the SFA and producing an acute embolic-like situation. It's not embolic, it's because of the obstruction and thrombus formation. And sorry, this is upside down. You can see on the left leg, you have that the whole artery is blocked. And then we had to do a thrombectomy. You can see how deep, very obese patient, artery is very deep, supragenicular popliteal artery. You can see that little blackish instead of the red area of the intima. And that is the clot removed from the infragenicular popliteal artery up to the angle. And then I've used a femoropopliteal bypass. Immediately patient was comfortable, free of pain, and could leave hospital in 7 days. That's the difference between acute iatrogenic or a thromboembolic feature or a chronic limb which is well collateralized. Now this is the Doppler scan after we have done the surgery, and she is absolutely fine at the end of 1.5 years. Now in contrast here you see the iotogram, and the left side it is a focal lesion which is about 80%, and right side it is stars D, meaning from aortic area just a nipple-like projection and the reformation of the femoral artery. So we have a patient with bilateral femoral and distal pulses absent with more severe symptoms of claudication on the right leg. But the CT angiogram shows it's a task D on the right and the task A on the left iliac area. This patient is 75-year-old, diabetic, hypertension, had 3 stents in the coronary system, and he had some abdominal operation as well. Then what I did was we opted for a stenting and angioplasty stenting on the left side. did a crossover femoral and he's doing well. I come to the next common feature after peripheral arterial disease, the carotid disease. Carotid disease, very important situation to identify in time, find the symptomatic patient, find the lesion concern, and go for either stenting, carotid stenting, or carotid endarterectomy. Carotid endarterectomy and stenting, both we do at both the hospitals. But primarily, we focus on carotid endarterectomy because it removes the focus of epicenter of the ulcerated plaque, and so that the patient is better. We put a vein patch and give you some examples here. This is the history to remember how difficult over 150 years we have come to this stage of carotid endarterectomy or stenting. This is the stroke team that we have made, Swasti. Symptomatic more than 70%, asymptomatic more than 80%, not immediately. After asymptomatic 80% can still have medical management for about, say, 6 weeks to 3 months and see some difference, or when symptoms occur. So we follow the Sambris protocol for intracranial disease, same medical management we put through the patients. A lot of studies have been done, many studies, ICAR study, CREST study, MESA study, I think dozens of studies on carotid disease and the brain difficulties, and to prevent stroke is, as we all realize, is most important. Now, when not to do, not important for this. Some of the examples here, you can see a very tight stenosis, 90% after a vein patch, after removing the offending plaque. It is normal and the patient is fine. This is another a hairline continuity, and you can see the post-op duplex hand on your right. It's widely opened, the internal carotid artery bulb, and you have the offending plaque on. This patient was a retired school teacher who was diabetic and hypertension, still keeps coming for follow-up with us. Now, of course, this is another professor of psychology who came with you can see the red arrow pointing towards a white area in the brain. He had stroke for about half an hour. Then he had difficulty in moving his left upper limb for about 3-4 days. We call it minor stroke. But when he came to me, he had recovered well. But that you can see almost a hairline continuity and small looking internal carotid artery. Again, that is the angiogram. It shows an ulcerated plaque. You can see the carotid artery. The hypoglossal nerve is hooked up. And then that is the one nerve which is shown magnified. You can see on your right, ulcerated plaque. In endothelium, the plaque, there's no endothelium. The plaque shows a lot of the small particles, atheromatous particles, and some clots, which is produced atheroembolism to the brain. So everyone now recognizes it's the atheroembolism producing blockade of intracranial vessels rather than the degree of stenosis. Degree of stenosis is important, but the other one, the embolic potential, is more difficult. Difficult for the patient producing symptoms, as well as it can even have rupture and can have a massive thrombus going up, and it can be even fatal. I think these are not so important. I think I have been fortunate to do several, I think a few hundreds at Sri Chitra. We started with almost like 10 years, we have done 39, but I think we had the stroke team, we got almost more than 250. In new hospital, of course, the caseload is not less, especially with the advent of this COVID situation. The patient's difficulty is towards COVID and trying to save life. Some of the pictures to show you, we use a inner shunt while we clamp the carotid so that the brain is perfused after 5 minutes, during which time we remove the plaque and we put the shunt, and you find that 142 systolic and radial, and we have a shunt pressure of 122. This helps us to seed the vein graft 98% of the times. When vein is not good, we use a Gore-Tex or a Dacron patch. But it's an indigenous material, patient's own, less costly, and living endothelium. So we almost always prefer the vein, saphenous vein, about 5-6 centimeters long, just above the medial malleolus. This again, on the top left, you see how widely the internal carotid is opened up, and you can see that this below that you have find a 12-year follow-up of a vein patch. So this I'm stressing because there is still, when the internal carotid artery looks little largish, There are surgeons who may do a direct repair, but I think that it again reduces to 80% when you take the edges and suture. Always better to put a patch. That's a lifelong gift to the patient and stroke-free life for and quality life for rest of our life. You can see the duplex scan there, which is really good, as I mentioned. You can see the right-hand side upper, you find that it's an ulcerated plaque. Coming to the sectional aneurysms, the aneurysms are fatal unless we treat them, intervene them, when at least the threshold of diameter is about 5.5, which is the most important determinant for intervention. But of course, in a smoker, in a hypertensive, in a COPD patient, the rupture of incidence of rupture is a little faster. So we may choose maybe from 5 centimeters upwards, because it is like a bomb placed in the ground. It's a question of time. So once you have an aneurysm of 4.55, it's going to blast, and then a ruptured aneurysm leads to more of mortality, whereas elective, we can have a safe endovascular open surgery. And we come to that. We at Sri JIPMER Institute and thereafter, we find patients come between 60 to 70, smaller body surface area of say 50, 60 or 70 kilo. And we have had excellent and late and early results. It has got a durability of lifelong. Patient will most likely, more than 95% once they go home after surgery, they have minimal follow-up requirement, minimal testing, and it's durable for their life. And easy surveillance and cost-effective it is. And of course, that is the method we are using. And I would have mentioned earlier, 364 open surgery we have done, whereas we have done EVA 20. I think in our patients, my personal take is open surgery is durable, most effective, less surveillance requiring, less costly. Whereas the EVA or the endovascular, which is getting common, is costly, little bit of mistake ridden and difficult to surveillance, and late recurrence is there. And there's a 8 to 9% of rupture because we don't remove the clot and switch it back. And the inlying endovascular, the aortic stent, it does not rule out. There's a almost 8 to 10% rupture in long-term trials, but I think there are selected patients who will only take EVA for a proper surgery, and open surgery may be too risky and life will be lost during surgery or post-operative time. So it's definitely a complementary procedure, but we are highly selective about the endovascular aneurysm repair. So that's the way we work up. We've got a large experience of 20, 25 years, and now we have good devices. We can have cell saver when blood loss is there. Suture materials are class. And in abdominal surgery, first choice, as I mentioned, is open surgery, and EVA are selected. And thoracic is just the reverse. Almost 90-95%. Last 10 years, we've been doing endovascular, including the arch aneurysms, whereas open aneurysms are limited. The huge size or dysphagia, patient having dysphagia, or cannot afford money. That's also good, 5 to 6 lakhs for the procedure. So we use open surgery. Some of the examples of aneurysm, how it looks dilated, and that the eccentric thrombus. But again, on your left is a large aneurysm. This aneurysm with a thin wall may not last long. And we have to use, many times we use bifurcated graft, but not mandatory if iliacs are normal. Now, in coming to the thoracoabdominal aneurysms, we have a series of 128 aneurysms with an overall mortality of 16% now, almost 5 to 10 years, I would agree. We have done some hybrid TVAR also for thoracoabdominals, but much less number, especially in type 1 and 5 only. This is the classification, Crawford's classification of thoracoabdominal aneurysm. That's one of my early cases. You can see the aorta, descending aorta. He had Takayasu's disease. Is 3 times the size of the heart, and the entire graft is sutured post-subclavian to above the inferior mesenteric artery, with just 2 open vessels of superior mesenteric and left renal, right renal available to reconnect. And patient, I have seen him till last 5 years, but recently I have not seen him. It's one of the biggest aneurysms I have operated, type 2 thoracoabdominal. This again, the operative picture, It looks like a ghastly procedure, but anyway, open surgery is a little massive and stressful procedure. This one almost post-subclavian to terminal aorta with left renal artery, which is included in the graph, and of course, the rest of celiac, SMA, and right renal in a patch, in a carrier patch on the right side. Now, this is the way we use a aortofemoral bypass temporary and put a plastic tubing 3/8 connector and use the inarapuri carotid shunt, and that's what is going the arrow show into the SMA, and left renal is the last on top, which is now insertion is almost at 4 o'clock, 5 o'clock position on the aorta. So we perfuse it minimally, although, but at least 200 cc per minute blood for a while of 1.5 hours, so that there's no total ischemia. This is a patient who came with Centric Angina. That's the next topic I'm going to say, the aortic dissection. So I was forced to manage the Centric Angina because SMA was underperfused. We tried to do a fenestration, which was not successful. I had to do 10 days after when he came, acute Stanford B dissection. I did a SMA bypass, and 3 months later, we did this procedure. We replaced the upper descending thoracic aorta where it was dissected. The patient is coming to follow up. Now, this is the endovascular aneurysm repair in nutshell, as I told you. Over 2007 onwards, we've been doing 162 patients. Some patients rarely, they require two aortic stent grafts, depending upon the length of the aortic segment involved. We have EVAR of 20 only. The rest of them has been 146. We have been doing on the thoracic domain because the patients are sick. They may have some associated lung problem, cardiac problem, then they have a coronary problem. They are not fit for major surgery of thoracotomy and cannulation, a lot of heparin, a lot of stressful thing, blood loss. So I think the stent graft is most valuable in the thoracic domain. Now, these are some of the examples of earlier we used to do ascending left carotid bypass so that we can at least get 3 centimeter proximal landing zone. And this is again come in the JVS as a cover page on the right. It is distal ascending arch and 2 stent grafts into the thoracic aorta with ascending bicarotid subclavian bypass. And patient lived 5 years and died of some other reason. He had a very good quality of life during that time. This is one patient, intramural hematoma ruptured. Again, we did the carotid and carotid subclavian bypass, and we have used the stent graft to cover the ruptured intramural hematoma. Now coming to a major subset. See, acute aortic syndromes are fourfold. One is aortic dissection. It's more deadlier than aneurysm because aorta is split into 2, and then it can produce a compressed true lumen and a large false lumen, produce blockade of blood supply to major organs like kidney, spinal cord, and superior mesenteric artery, and it can be very devastating situation with high mortality. Aneurysm rupture is a high mortality stuff. A threatened rupture can be salvaged early, and it's almost like the elective surgery. If you do it in the proper time, then we have this penetrating atherosclerotic ulcer and intramural hematoma. They are truly the precursors for Stanford B dissection. So may require, depending upon the size and patient's age, hypertension, and the size of the ulcer, number of ulcer, and various factors. This is what happens in hypertensive patients. Some of them even marfanoid. There's a break in the intima in inner media. Blood enters there, splits the aorta, which is a very near fatal condition, especially so in the ascending aorta. Descending aorta, this thoracic aorta, Stanford B, it goes a little slower lane, and they can be preliminarily managed with medical management if they do not have malperfusion and take for surgery stent graft, or mostly we do hybrid arch at the something like 80-90 days, that is 3 to 6 months time, so that the area is fixed and aorta gets remodeled. This is the important thing. It's a commonest catastrophic event affecting aorta. You can see on the bottom side how aorta, because of the false lumen, is bulging and it can rupture. This is the various classification we have. You can see a tear just next to the subclavian artery, we invariably do a carotid and deploy the stent graft next to the innominate artery so that you have a horizontal line with 3 centimeter proximal landing zone. There's no migration down, and also there is no retrograde aortic dissection. Now that you can see the split aorta there. This is another classification for management called dissect. And then, of course, the temporal classification of hyperacute, acute, and subacute, and chronic. And chronic, we should not leave more, because once it gets to 7-8 centimeter, it's almost impossible to treat. And in complicated aneurysms, having the dissection, if you don't treat them, almost up to the tune of 40 to 50% can die within a short while. I think I don't want to go into malperfusion syndrome. I already mentioned enlarging false lumen. And of course, the medical management called wheat and palm. What we do is we admit them in Stanford B dissection. Once we do the CT scan and confirm no malperfusion, they're admitted in the intensive care. Arterial line is placed to keep the systolic pressure between 100 to 110 using sonide, NTG, or whatever, an injectable beta blocker. Have a catheter to have a urine output of half to 1 cc per hour, and so that that there's no further dissection, and dissection is almost like halted. And then, of course, depending upon his progress, put him on beta blockers orally and take up for surgery 3 to 6 months later. I've done about 18 open surgery, but not till not beyond 2010, and we had this stent graft available. Now, of course, the best medical management has to be followed. You can use multiple options. Again, open surgery is almost non-existent for dissection. This is one classic example. You can see the true lumen, how badly compressed. This can be a big problem for renal flow, SMA flow, spinal cord flow, and that can lead to treatment. Here, there's been a good, post left carotid area and the post subclavian. There's a good area available, and the tear started just after the knuckle. So we used a graft there just next to the subclavian. This is a rare feature, but can be done in select cases. Now, this is a patient who had Stanford B dissection. You can see how narrow the outer side is, the true lumen, and how narrow it's become now full. Now, this patient came on 3rd day, massive hemothorax and the dissection starting from subclavian artery. Here we had to do a synchronous surgery, carotid to carotid bypass, and deployed the stent graft at the post innominate area, and had a graded ICD drainage for the hemothorax, and that is the result. He was discharged on 12th day or 13th day. The hemothorax cleared, and he keeps coming for follow-up after this near fatal situation, appropriately tackled. This is one of my first cases. He was working in Abu Dhabi with, and then we need a hypertensive crisis. Then he came here to Ruptured, and he was referred to us, and we have done the treatment. And we have about 152 patients with thoracic endograft. We are very happy with the procedure, and we have got pretty much good results as well. Almost half of it is on the hybrid arch. Hybrid arch, of course, the split up, mostly aneurysmal, but next Stanford B dissection. And this is the one which I already shown. Now, one more word I would like to mention. It's very common for patient to come with chest pain. And in any patient coming with severe chest pain, the first diagnosis one considers, and one must consider, coronary event. You do an ECG, you do enzymes, and you do the TROPT test, and then you find that it's negative, and there is a hypertension, and the pain is more interscapular and backwards. That's the time to do what is known as a triple rollout, to do a CT scan, and to roll out between pulmonary embolism and Stanford B dissection. Stanford B A dissection will come with mild hypotension. Echo and CT will find out definitely whether it's a Stanford A or B. And B, we treat the same way as I alluded to. And A means emergency surgery, because 30% of Stanford A patients who develop dissection at the ascending aorta die without diagnosis or without treatment, getting treatment in the hospital. Rest 1% mortality per hour, with the result at the end of 15th day, there will be hardly 5% of Stanford A, ascending aortic aneurysm, dissection people alive, whereas the Stanford D is on the slower lane, and we got some time because the one ascending aortic can split up the coronary, can rupture into pericardium, can produce a massive AR, and of course the heart cannot sustain acute AR with one leaflet totally drop down to the LV outflow. So that is very important to identify. So we use this to rule out these three important life-threatening. Once you have ruled out all these three, generally the things are not in that kind of problematic. You can manage maybe pleurisy or some effusion or chest pain. It could be something less formidable, and of course these are the ones which will be fatal almost immediately. Now, I think nowadays we find increased incidence of vascular diseases due to the demographic, that is the more and more elderly patients, 75, 85, 90, like, then its effective intervention and surgery is available to save the patient's life, and improvement in quality of life, very important. Then of course, even in the place where I work these days, we have got a full state-of-the-art endovascular procedures as well as open procedure. Not only that, there are more complex cases we have tackled, but this I just wanted to introduce to you what is generally the starting with peripheral artery disease, carotid artery disease, the aneurysm and dissection. Of course, this vascular surgery is much more. And I want to reiterate once again, vascular specialist is a surgeon, is an interventionologist, and a physician. And this is the combination at varying proportions. Personally, I feel a team has to be there to discuss, plan, because it is very important, critical to plan your job, because if you fail to plan, you are planning to fail. That's most important, especially in any vascular problem, particularly so in endovascular surgery. So thank you for your patient hearing, and I have finished my the presentation. Then I'll just half a minute later, I'll take your questions. So, ladies and gentlemen, I will read out the questions and try to answer. But at the outset, I'll tell you, I think difficult questions, more of vascular medicine. And to me, many of them looked intimidating. But anyway, let me try it out. What's the role of mitochondria in the development of abdominal aortic aneurysm? Sorry, no answer. I don't know. What is the role of genetics in predicting the chance of developing AAA? Let me tell you, gentlemen and ladies, I have been in business from 1985 when I had finished my MCH, then helped Professor M.S. Valiyathan sir and Dr. Neelakandan sir, started independently from 1990. So I must have done 364 plus 20, 384. Another 50 I would have seen. We've never seen any familial or genetic problem for abdominal aorta. So again here, my answer is I don't know. What is the prognosis of treatment of endovascular disease with endo anchors? In fact, endo anchors are used in Western countries, but I don't know if anybody uses here. We have never used. So I'm sorry again, I don't have an answer to that. Aortic neck dilatation occurs after EVA with primary endostapling Is that dependent on the type of skeletal platform used? Again, sorry, cannot answer. What are the risk factors for post-discharge bleeding after endovascular therapy for peripheral artery disease, and how is it managed? Generally, in peripheral arterial disease, when you have done endovascular stenting or plasty, the few risk factors underlying is renal dysfunction can lead to hemorrhage. That is one. Plus, of course, if they are on oral anticoagulation, especially full dose of NOACs, neo-oral anticoagulants, then I think for whatever reason, maybe distal runoff is not good. There's been an angioplasty, so you have to protect that. Whatever reason. So if one is using oral anticoagulant, then of course there is more chance for bleeding. Then of course if the patient is getting dual antiplatelets, that can be a potent cause for bleeding in such patients. So what we have to be careful is that we have to modulate our treatment when there's a renal impairment. And then of course, use these medicines carefully, especially NOAC, there is no way to monitor. So we have to be, again, the renal impairment, you have to have modulation, and you have to reduce it, and less than 30 ml for EGFR, say, creatinine clearance. It is better not to use it. If it's a must, you have to use maybe apixaban. What are the pigmentation and intravascular clots frequently occur with STS 0.2% sodium tetradecyl sulfate treatment in case of management of telangiectasia with sclerotherapy. Why does this happen? Please Google this. No idea. Never done one. According to the Journal of Vascular Surgery, non-syndromic familiar thoracic, Stanford thoracic B dissection, type B dissection, was twice as common as syndromic TBAD and appears to share many clinical features. What are clinical presentations of non-syndromic familial TABD? Sorry, no answer. I don't know. What are the long-term symptom improvement and health-related quality of life after operative intervention for median arcuate ligament? I have seen 2-3 patients, and then we have requested for a laparoscopic release of this, followed by a celiac stenting. But although I have seen 2 or 3, the patients, because of unwillingness from patient side to undergo, and unwillingness to go divide the median arcuate ligament, because there's no point in putting a stent when there's a ring obstructed. So again, I don't have a proper answer. Among the many complications, stroke has been an increasingly reported complication. Of what are the predisposing factors and reasons. Actually, the COVID is an exciting area, rather intriguing area also. Intracranial stroke and thrombosis can occur because of, number one, platelet adhesions, and also the cytokines released by the virus in large numbers, and then it can lead to arteriolar thrombosis and an acute shutdown. When there is an asymptomatic plaque in the carotid, extracranial carotid artery disease, in view of this COVID thrombogenicity, high thrombogenicity, that can misbehave, can lead to stroke. These are the 2 reasons I know of. What are the diagnostic modalities for a case of complex aortic arch anatomy? I think it is TE echo, then contrast aortography, then of course IVUS. What is the hybrid emergency room management procedure for a case of ruptured abdominal aortic aneurysm? Here we can use a Corda balloon. It's available of 9 French is the size, but you need a larger sheath. So unless it's a big man, I don't think we can do a cut down through brachial. You may have to pass it through femoral artery and then control the supraceliac, also definitely suprarenal aorta as a life-saving measure to get some blood pressure and take up for your open surgery or endovascular, as the case may be. how do we manage a case of iatrogenic abdominal aortic pseudoaneurysm? I think best EVAR is the best way of to go ahead. And redo surgery is very risky. So this iatrogenic pseudoaneurysm, whether it's postoperative, surgeon made, or a traumatic. Traumatic is extremely uncommon. So it must be mostly postoperative. So a stent graft, EVAR is the best treatment for that. And question number 13, what happens in a patient with bilateral absence of common iliac artery? I don't know. I don't understand this question. What happens in a patient with a bilateral absence of common iliac artery? I suppose it is the common iliac artery is occluded because of Lariche syndrome and the extension. So what happens? He has claudication. He has no gangrene unless there's complication of thromboembolism or distal diseases in the tibia, and of course impotence. That is what. And this does not produce gangrene at all unless, as I mentioned, there's a distal disease or a thrombus. Then, in a case where the patient has got bilateral absence of common iliac artery, how do you preserve the internal iliac artery flow during endovascular aortic aneurysm repair? Tell you frankly, I cannot answer this. What is endoleak? Endoleak is related to endovascular aneurysm repair. 1, 2, 3, 4, and 5. 1 has got A and B. A from the front, the proximal side, and B, 1B from the distal. Type 2, the branches producing blood into the sac and producing the enlargement further. Type 3 is because of the separation of the modules. Like, for example, as you know, EVAR has got a ioto right or left iliac, which we deploy first. And then there is a small gate where we put the independent iliac. So rarely there can be some fracture of the graft material, or even a dislocation or a separation. That is called type 3. Type 4 is porosity, and type 5, you don't recognize any endoleak at all, but you find this endotension. The tension increases and the size increases, and that, I think, if you don't find anything, could be one, in difficult cases, it can be a reason for late conversion. Novel prefabricated bovine pericardial grafts are considered to be a good alternative conduit for septic aortoid reconstruction. What is your opinion? Definitely it is. One of my, I think 2 of my colleagues, younger colleagues, who were trained for MCH and vascular surgery with me, they have done Ajay Savlania in PGI and Shivaneshan in my own institute. They have done two cases each. I think I'm pretty happy with it, because sometimes the harvesting both superficial veins and putting them together to form a trouser graft, it can involve some time, 1 or 2 hours. So we have to, we can use this bovine pericardium, make a tube graft. I mean, the bifurcation graft. In the United States, the first annual Women's Vascular Summit highlighted sex and gender-related knowledge gaps in vascular disease diagnosis and treatment. Do you think this exists in India too? I don't think so much of diagnostic dilemma is gender-oriented, but I have found that if a procedure can give a benefit of 90% for men, it is only 60 to 65% in ladies. I have seen it consistently 4 or 5 patients. Fortunately, out of 20, only 1 or 2 are women, most are men. But I think there is a difference. Things don't work as well, maybe because of the size vessels and the whatever hormonal change or whatever, I do not understand. But the results are much less than what we get in men. Now, according to an AVMR, Annals of Vascular Medicine and Research, it was seen that among OHCA, out of hospital cardiac arrest patients, ROCS, return of spontaneous low and levels on admission were recorded. Can NLR be used as effective mortality? I do not know, sir or madam, whoever is asked this. What is the safety rate of femoropoplar endovascular treatment with peripheral drug-coated devices? I think it is safe, although with sirolimus they have found that there's an increased cardiac mortality. But that is little controversial. But it is true that in most studies, there is a increased cardiac mortality in when we use this drug-coated device. And last one, what is the association of anti-angiogenic drugs with artery dissection? So aneurysm among patients receiving anti-angiogenic drugs for the treatment of cancer. This association of angiogenic artery dissection. Well, no experience. So thank you very much for listening, and thank you very much for asking this very difficult question. Almost 50% I couldn't answer, which only means I should be doing more reading when I have more time. Thank you so much to the right doctors, and thank you for listening the whole distance. Thank you very much.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.